pain for 4 weeks. She says the pain occurs only in the mid range of motion, about 60 to 120 degrees of flexion and abduction. When reaching overhead for objects, which he has to do a lot recently. Oh, I wrote he. I'm sorry. She's trying to fix that right now. For work. She also notices this pain when getting dressed in the morning, especially when looping her belt. And when sitting at her desk for long periods of time. X-rays were negative for bony abnormalities. Okay. What do you guys suspect the diagnosis is just based on this fantastic description of this patient?
Case number 2.
We believe she has SAPS,
Which stands for?
subacromial pain syndrome.
Thank you, Jackie. All right, now show for the subacromial space, use the skeleton or Frankie the Butcher to explain the following to your colleagues. Where exactly is the subacromial space?
Aquí. Here.
So the AC joint is the superior border.
In this area.
The inferior border is what? The coracoid.
This one right here.
Very good.
So like this
And
between
it's
this.
the
anterior shoulder.
Yes, and what goes in between there? What structures go in between there?
Supraspinatus tendon, long head of the biceps tendon, subacromial, coracoclavicular ligament, and humeral head right there, and bursa.
All right, so the bursa, subacromial bursa, the long head of the bicep tendon, and the supraspinatus muscle and tendon. Okay, very good. Okay, how does certain range of motion affect the subacromial space?
So my finger is like the person.
Yeah.
And crush it like when I abducts.
What range of motion? So we have abduction. When you get to a certain, what degrees of abduction? 60 to 120. You see how this all comes together?
Yeah, sorry.
Good. 60 to, right, wow. 60 to 120 is when the greater tubercle is right in the subacromial space. What other range of motion?
Flexion.
Flexion, yes, when you go into certain degrees of flexion, right? I would say even the same range, around that range, at 60 to 120, the greater tubercle goes right into the subacromial space. And finally, internal rotation. When you go into internal rotation, the full internal rotation really gets that head, the greater tubercle, right in there. Thank you. Good. Discuss how the following factors contribute to decrease in subacromial space. Extrinsic, biomechanical, and intrinsic. What's an extrinsic factor that can contribute to this diagnosis?
Bone spurs.
Yes, bone spurs. Unfortunately, physical therapy doesn't always help with bone spurs. What do you say about that, Carlos?
I agree. We can manage the pain, but we can't change bone structure.
Yeah, so if it's a bad case, that's when surgery is warranted, if it's a bad case. What's a biomechanical factor?
Poor posture.
Poor posture. What else?
Abnormal scapular humeral rhythm.
Right, or weakness of muscles, right? Very good. Rotator cuff muscles or scapular humeral muscles. What else? Tight pecs. When you have poor posture, you have tight pecs. That crushes the space, right? Got it? Those are things that are biomechanical factors. And what about intrinsic factors?
Degeneration of tissue due to aging.
Yes, so those are intrinsic factors that you have degeneration of muscle, and that's why you have issues with pain in there, right? Very good. Okay, now, the patient complains of pain in what anatomical location of their shoulder? And don't use fancy terms because they pump gas for a living, so they don't know fancy anatomical terms. The patient will say, I have pain where? What?
At the front of the shoulder.
The anterior shoulder, that is 100% correct. And the ADLs, you already said them, but say them again. What's one?
Reaching overhead.
Yes, based on the case. What?
Yeah, reaching overhead.
Reaching overhead, looping their belt.
And
Sitting at a desk.
for a long time.
How about tucking their shirt in or not this case?
That wasn't this case.
That wasn't this case. All right, excuse me. All right, your patient specifically mentioned pains occurs in mid-range, 60 to 120, right? All of a sudden they're educated. Inflection and abduction. This phenomena is called
Painful
The painful arc that everyone answers. How does this occur? Show us an abduction. Where's the greater tubercle? There it is. At 6, go slowly. Start at 0 degrees of abduction. As the patient goes into abduction, around 60 degrees, that greater tubercle goes right into subacromial space. And about 120, it leaves the subacromial space. So the patient will complain of pain from 60 to 120 because that is where the greater tubercle is in the space, making the space very small and putting pressure on all of this, the areas that you mentioned that are now inflamed. Okay? How do you test for this phenomenon? Who's going to be the PTA and who is going to be the patient? And begin. So,
Jackie's gonna be the patient, and you're gonna be the patient.
okay.
Jesus Christ. Whoa.
Yeah, sure. Alright, so how I would have her test for this? Okay. We have you swing your right arm up out to your side and then up to the ceiling. And then what I would test for is see like when she starts having pain and then if and when the pain goes away.
All right, so that's how you do it, and you say about 160 degrees pain, about
Professor.
at 120 degrees no pain. Yes.
Oh, went away? Okay.
Question. You have a question with that? Huh?
I thought the thumb has.
The thumb could be an external rotation. That's fine. But that is it, right? It's a very simple test. For they would say positive, painful arc, right? Very good. All right. What's next? Scapular visual inspection. Upon scapular inspection during range of motion, what would you notice, Adib? I was going to take your shirt off again.
Scapular winging.
So you will
Forehead,
see
so-
scapular winging.
Yes.
And what is scapular winging?
Wow. Do you want to see it or what?
I'd rather you say it, but you can
It's
show
like
it.
when the scapula is like.
Speak like a
tilted-
professional now.
tilted- Okay.
So what parts of the scapula are leaving the thorax during typical glenohumeral range of
The
motion?
anterior portion of the scapula is lining up on
The inferior border pops off. Show us Frankie the Butcher.
the inferior border of the scap pops off higher.
Yes, and what other part?
The superior
Medial.
portion.
Medial.
The medial portion.
Don't play dice because you're saying every part but the right part.
Sorry.
Yes, the inferior border pops off the thorax, or the medial border of the scapula pops off the thorax. During regular movement, right? What I have the patient do is take a 5-pound weight and do repetitive flexion, and you'll start seeing the scapular winging. That's what scapular winging is. Very good. What weak muscles will contribute to these scapular deficits?
Weak upper traps. rhomboids.
Upper traps,
Serratus anterior.
serratus anterior,
Mid traps.
mid traps. So it's
Lower
mid
traps.
traps, lower traps, and serratus anterior. What do they all perform? Together they do what? Upward rotation. So if those muscles are weak, your scapula is not moving properly, and that's when you see these weird scapular movements. Okay? This is called again what?
Winging?
No, but what is when you watch the scapula move weirdly, it's called what? Scapular dyskinesia, right? Scapular dyskinesia. What specific test can you rule in if you do a painful arc? What specific test can you rule in to use to confirm that the patient does have a painful arc?
Scapular assistance test?
Yes, how do we do the scapular assistance test? You won't do it better than Kat, who did it yesterday, right? You did it yesterday?
Yeah, I can't.
Who
So
showed
it's
it?
the same
Right.
thing
Yeah,
as
Kat.
we did.
Kat showed us yesterday.
Yeah.
So what are we doing?
The same thing that we did earlier, except for
Okay.
now the therapist assists.
So
the
this is
scapula.
what the video is. Show us. No, I didn't say don't show this.
Oh,
I said you don't have to show
all
Gonian,
right.
manual muscle testing, and joint moves. Are these one of those three? No, thank you, Russ. Finally, you got my back. Finally.
Okay. So my hand's gonna be along the inferior border of her
Yeah,
scapula. Then
yes.
we have her abduct her arm again.
Yes.
This time I'm gonna.
Good. But I would, because I'm not as strong as you, Jackie, I would do with inferior and superior and the spine and go into abduction again, and then I would do it.
Oh.
All right?
Okay.
So get it on both sides and help. All you're doing is helping it move, because if it's not moving properly, that will help it move, okay? The mark I gave you will go away in 2 days. All right. Now, I tend to have heavy hands.
That's fine.
That's why they all love me there. All right, active and passive range of motion testing. What range of motion will be limited?
Internal.
Internal rotation. You're reading the next case, by the way, Carlos. Internal rotation, abduction,
We
and
can read
flexion.
our we can read our own
Again,
case.
for this case,
I don't
you
want
will
it.
have to show us how to do goniometry for those 3 ranges of motion. We're not going to take the time to show you now. You learned it already, but you better practice how to do the goniometry for those 3 ranges. Thank you. What about manual muscle testing? What's weak?
Lower traps.
You already said the 3. Lower traps, serratus anterior, mid traps. What else is weak?
So those 3.
External rotation.
External rotation and
Supraspinatus.
what range of motion is that? Abduction. So in external rotation, abduction, and the 3 muscles that perform upward rotation are the serratus anterior, mid traps, and lower traps. Those are the muscles that are weak. Again, we're expecting you to do manual muscle testing for those ranges. Okay? Excellent. We're not going to show you to you now, but you're gonna have to do it. Postural assessment. Show me some crappy posture. Somebody. Good. Okay, so when the patient sits like crap, what's tight? Pecs are tight because you're shortening them. What's weak?
Mid trap.
Scapular muscles. All the scapulohumeral muscles are weak because you're putting them on a weird position. So these are weak, these are tight, and you'll have scapular dyskinesia if a patient sits constantly with bad posture. Very good. Any questions thus far? Excellent. Now for the special tests to rule in the diagnosis, which you probably think the patient has because everything they're telling you so far is screaming SAS, right? Okay, what's the first special test?
First one we put was painful arc, but we already.
Well, we did painful arc. A painful arc is not officially a special test, but okay, we got it.
Well, we kind of had it as painful art plus adding the.
Okay.
Yeah. We kinda
I give you a
did those
thumbs up for
together.
that. What's the next special test you're gonna do? So Job empty can, great. Is that one of your special tests?
Yeah.
How do you perform it on your patient? Show us in front of the camera.
Yes.
I thought we worked all this out. We did blocking. Everyone got their scripts. No.
All right.
We do.
Elena, just stick your arms out in front of you and turn your thumbs down.
Okay, and then what do you do next?
So we're just going to resist both her hands as you raise them towards the ceiling. Raise the roof, Elena. Nice. Ouch.
You
That's
are
a positive
resisting.
test.
You're resisting flexion and full internal rotation. But why did you choose to internally rotate the patient's shoulder?
Because she has problems with her internal rotation. And
No, why are we
Humeral
doing
head,
because
where
in
you're putting
internal
the
rotation,
humeral head, yeah.
see, doesn't it make sense? The reason why you internally rotate because that is the worst position for the subacromial space, and when you resist, you're making the long head of the bicep fire. So the tendon now is firing. If it's injured because of subacromial impingement, you're creating a very painful situation, which is what the purpose of special tests are, just to recreate pain. And that's why I love doing that. Damn it. Okay. What's the next special test? Get Jackie losing it.
Hawkins.
Thank you. All right, what's the next special test?
Pain weakness with persistent shoulder external rotation.
Okay, what's the next special test?
Hawkins.
Hawkins Kennedy.
That's twice.
It used to be Hawkins Kennedy, but
14-minute
they call
video.
it Hawkins now. I guess Hawkins and Kennedy got divorced, so it's just Hawkins.
That's-
All right, what is
that's
the
sad.
what is the? They don't call it Hawkins Kennedy anymore. It's Hawkins.
That was good. I didn't.
I don't know
We don't
what
got
happened to
time for.
Kennedy.
We're
All
running
right.
out of memory space. The video is gonna loop.
What is the Hawkins sign?
So,
Do it on your patient.
alrighty.
Doing it on yourself is just weird.
I didn't know how to do it.
So then why are you doing it?
Yeah, this is what you can expect.
All right.
So,
So,
we're gonna go.
what could the whole group see as well?
Get over
Thank you.
here. What are you doing?
I'm
All right.
seeing just
So
fine.
the patient
Do you?
has 90 degrees of shoulder flexion and elbow flex about 90 degrees,
Do I have to
45
go on
degrees.
this shoulder?
That's
No, you had it right.
Oh, maybe. Sorry.
and then you are now forcing the patient into what?
External rotation.
Into what?
Oh, internal rotation, but she's gonna externally rotate.
No. You're passively bringing the patient into. This is why you practice, so you don't embarrass yourself in front of the camera.
Yeah.
You force the patient into internal rotation. But why are you doing that?
Because it creates pain again.
Because you are making the subacromial space tiny, and you are crushing all the structures there. So a positive sign is what?
Ow.
Ouch.
Pain. You are reproducing the pain because you're creating the most painful possible experience. As I said yesterday, every one of these special tests involves internal rotation. What is the last special test?
Near.
Near. What is the near sign?
I'm out of here.
Get this guy out of here.
Steve, don't leave us. That's my chair.
Someone else got it.
Okay.
What is the near sign?
Okay, near. So
not go
your
over
palm
there.
facing the other way, and you're just gonna lift
No,
your
it's
arm
a
as
passive-
high.
It's a passive test.
So you're doing it.
Okay, so I'm doing it then.
Yes. So you put the patient in full internal rotation. Do I have to ask again why I'm putting the patient in full internal rotation? Because you're making the worst position. It's a passive test. So near, do it again. Put the patient in full internal rotation. Passively bring him into max flexion. Between the internal rotation and the flexion, you are making the subacromial space tiny, therefore crushing all the structures that are injured. Therefore, a positive sign is pain. Are there any questions on those special tests?
No, it's gotta do it.
You gotta practice, man. You gotta practice, but you'll get it. In fact, when I get this diagnosis, I'm coming to you, Adib.
That's fine.
So you could treat me.
So you have to do all of them stuff?
For what? When a person has this, I do all these tests. But as you get good, it takes
And then
not.
you can take the order or?
You just-
Well, just finished and then we.
All right, now the red flag. Now, briefly discuss what a GI ulcer is and how from NSAIDs. Yes.
Right, our answer's not very brief, but I'll try to keep it brief.
Oh.
So, history of chronic NSAID use and history of previous ulcer is a red flag. It's the most common cause of medication-induced shoulder pain in all ages. Upper abdominal or GI problems with diaphragmatic irritation can refer pain to the ipsilateral shoulder on the same side as the affected diaphragm.
All right. Everyone understood that but me. So if the patient, because I'm simple, I'm a simple guy. If a patient is taking NSAIDs such as
I don't know.
A lead.
ibuprofen or Aleve, yes, those are the classic ones. What does an ibuprofen or Aleve do? They are type 2 COX inhibitors. What do? They stop what? Why would I take Aleve? Inflammation. The problem with them is they stop inflammation everywhere. It's like an AR-15 when you only need to stop inflammation in one spot. The negative of that is your GI tract from your esophagus down to your gut is lined with mucus, which is a good inflammation. It will dry all that up. So people that have used NSAIDs can get an ulcer. It means a hole in the esophagus because you already dried up all of the mucus that protects it, and now you're putting a hole there because you take too much NSAIDs. A person with that can have pain in the shoulder if it's high up enough. Does that make sense? So if they have a history of ulcers and they take tons of NSAIDs, then you think twice before you think it's a shoulder diagnosis. I had one patient who came to me, he goes, yeah, I've been coughing up blood lately. I'm like, what? He goes, yeah, I take ibuprofen. For how long? He goes, oh, for 5 years now. 6 pills a day for 5 years. I'm like, what? Why? He goes, well, the doctor told me to.
So something we could ask them is, one thing that is different is when people eat, the pain can go away. So that's one thing we thought we could ask them.
All right,
about
swallowing,
NSAIDs.
lying down, the pain gets worse. A lot of times with ulcers. All right, very good. Now we're up to treatment. So we want to see, first, phase 1, eccentric strengthening of the internal rotation of the arm at your side. So how do we do? We're doing eccentric internal rotation and eccentric external rotation.
So eccentric internal rotation, we're already here, and then we're just bringing it back slowly.
Very good. You see how that's eccentric internal? The patient's going to external, but the internal rotator muscles are fighting it. And Carlos likes more than me that there is a towel underneath the armpit to stop nerve damage. And then how do we do eccentric external rotation?
Just switch them.
Switch it. So now we're starting here. We go into external rotation, and we're going slow on the comeback.
Very good. And like Carlos and I both like starting in a lot of cases eccentrics because you're strengthening without hurting. Now what about an eccentric abduction exercise from 90 degrees?
So we're already here, and we just slowly lower this.
Okay, very good. Now, let's see concentric open chain serratus anterior.
I can
Anne
just do
Marie
this.
is going to show it. I don't like that one. Because the line of pull from, you have to make sure you're going the opposite from the line of pull. Does that make sense? Do you want to do that? You want to be supine?
Yeah, I was
Exactly.
gonna, but they were on too.
Alright, so you just punch forward.
Let's see a few of them. With the elbows do not bend. And I'm gonna tell you right now, the patient is gonna wanna bend their elbows for some reason. You tell them not to bend their elbows. For most people, it's a weird movement for them. Okay, excellent. You also could do it supine. Show us quickly, Adib. Same thing, elbows do not bend. They are punching the sky. Excellent. All right. Now, how about a concentric open train mid-trap strengthening?
So if we only have one band of, like.
We don't have one band. You can take that one and wrap it around so you have two bands.
Oh, you should put-
Where Anne Marie's is longer. Anne Marie's is longer.
It's just the right one.
It's on video.
Almost there. Almost there. Good.
20-minute video.
Is that mid traps, Carlos?
Yes.
Okay.
We could also do full parts.
Is that more mid traps?
That's weird.
I think once you.
It's also deltoid.
Yeah.
Wanna get
Weird
technical?
dope.
All right, we'll buy it.
If you wanna get.
I think mid traps is more this. Once you're going this, it's more rhomboids. Though yes, you're working multiple muscles. But me and Carlos could fight all night about muscles, right?
All
We
night.
do it all night. All right. His wife yells, "We're still on the phone talking about muscles," but she's a PT, so she gets involved. All right. Now, how about lower traps?
Oh, there's the lotus. Yeah, yeah.
Alright.
Carlos loves this one.
Loves this one. Press. There you go.
Wow.
With the left?
Press.
Excellent. If you're more simple like me,
So he's
But it's-
pressing the shoulder blades.
I mean, he's
Press,
working on it.
Fingers towards the floor,
Get it?
or fingers towards his feet, and then go into extension.
see how it works the lower traps.
Right? The reason why I like this one rather than every PT clinic's favorite of the Superman is because here you can compensate with what?
Upper traps.
Right? All he's got to do is lift this up and the arm comes up.
He loves that one. She loves that one. This is what I like to do, but I like the lotus much better. I like because it's hard to find a place. No, to do it this way. Like you have to be able. The patient has to be able to.
Get my nose creases.
keep it down. And this is a lower trap exercise as well.
I'm sorry.
But it's hard. That's Carlos is much better because you can do that on the table. Mine, you have to find a place to put it, and then they'll put it somewhere weird. It'll slap them in the face. So that's why that one's better.
I've been doing this thing where they have me do an extension from the top and then rotate my torso. I don't know what the rotation aspect is.
Show me later. We don't have to throw up the video, but show me later. All right, now the what joint moves are you doing in grades 1 and 2? Because early on in treatment, it's grades 1 and 2 because pain is the issue. What joint moves are you doing?
An inferior glide and a flexion IR/AP glide.
So inferior glide and anterior to posterior glide.
Yeah, for flexion and IR.
Okay. We'll buy that. Again, you have to know how to do the joint moves. We're not going to show you here. You have to go and review them. You understand?
Yes, sir.
All right. Because Gus is falling asleep.
What are you talking about?
All right. Now, light, non-aggressive stretch to tight musculature listed in your assessment.
The pec stretches in the doorway.
Show us. Because the patient has poor posture,
Hey.
right? So you want to stretch. No, turn around, face the audience. Put your arms right, elbows bent to 90 degrees, both palms are on the, bring one foot forward,
One foot
bend
forward.
that front foot. Is he doing it right?
Yeah, he's doing it great.
Oh, yeah.
Never seen it better.
No, now I'm gonna see bilateral.
Bilateral.
Why would you
Oh.
do unilateral? Do bilateral because they're both tight. He's good.
Oh, jeez.
All right. Is there anything else that's tight?
His wallet.
Upper trap.
From this.
Okay, all right. And how would you stretch
We
your upper
have more
trap?
stretches later.
All right, look, check it out, check it out. Stretching the upper traps, excellent. So they're stretching the pecs, they're stretching the upper. Show us again onto the camera.
We got it.
Got it?
I see everything.
All right, good so far, good.
Can you push me
Now,
around?
phase 2. Shoulder flexion, show us concentric and eccentric shoulder flexion. What are you gonna use?
Use a weight.
Do it for real. Show therapists, show the patient so we have a good video of it.
Okay, so, imagine this is the weight in my hand, you're just gonna raise your arm to 90
Good,
degrees.
90 degrees. I don't like above 90 degrees, especially with this diagnosis, correct?
Precisely.
You don't want to start impinging when you don't need to. Good, so concentric and then eccentric.
Yep, exactly.
Very good. How about for abduction? Show us concentric to 90 degrees.
So I mean, you're up to
Good.
90 degrees.
And
perfect, you
then
know what to do.
eccentric. Good. How are you gonna do closed chain serratus anterior?
So we can kind of show these simultaneously, the next two.
Oh, so wait, so I can say mid traps and serratus anterior.
Yeah, so what we're gonna do, so for your serratus, you're gonna push.
See how that's closed chain? As her body's going up, that is protraction, therefore serratus anterior, yes.
And then retraction
Wow.
For the mid traps.
for mid traps.
That's concentric?
Yes.
It's closed chain, you're still fixed.
Yeah.
I don't know if that's concentric.
How? You're shortening the muscle?
Yeah. They're-
If it's just
Yeah,
like,
watch.
You're shortening the muscle, but gravity does it. The
No, no,
muscles
no, no,
aren't
no.
working, is
No,
my
my
opinion.
shoulders are not gravity. My shoulders.
Oh, your
are
shoulder,
She's
okay.
retracting your shoulder.
If the
Retracting.
patient is really able to do that,
I'm retracting.
okay.
What would you do?
For
What would you do?
mid-traps,
Mid-trap closed chain.
I might do go back there and just go sway to the medial and lateral.
Like this.
Is that momentum?
No.
Yeah.
Well, fine.
Sorry.
Oh, take Carlos aside. I guess if the patient's really cerebral about it, because if you just do nothing, you go into retraction.
We talked
But-
about that. We
Yeah, we
said
did.
that
All right.
if we go back and forth, then it becomes a plyometric, because they can use the bounce
All right,
of.
I
Yeah.
got it. Just make sure you teach the patient properly to actually actively do the rhomboids.
And
I mean, the
then-
mid-traps.
Lower traps, concentric, closed chain is this like bear crawl. So
Bear
you have
crawl,
to
show us a bear
pull-
crawl. Keep on
Pull
going.
here.
You see, that's a bear crawl, good. Lower
Sorry.
traps, because as you bring your body, your arm back and your body forward, that is low traps.
Wow.
Excellent.
Wow.
The grade 3 and 4 are the same things as
Same.
1 and 2s, except now you're doing the same positions, but now you're doing 3s and 4s. Now, self-stretch for the tight musculature.
Insert rotation towel stretch.
Show us. Using a towel or using a, you wanna use this? That's fine. You guys will use the towel, okay? So you see both.
Wow.
Go up till they can't go anymore, and they hold. Excellent. What else is a stretch? What else?
External rotation.
External rotation.
Show
Oh,
us.
the weight, right?
Yeah.
And you see the posture.
Notice the mistake that he did already, right? Instead of going into external rotation, he started going into extension, which a lot of patients do, right? They think, oh, I'm getting further. But that is not this. Okay?
Very good. Now, Jackie's sitting like crap. Elena, you're the therapist. What 3 things could she do to fix it?
Okay, so we said postural teaching. So Jackie, I'm gonna have you sit up. Can
Sit
you
up, that's
look
1.
Straight ahead. and-
Straight ahead, that's 2.
What were the-
And
Keyboard,
Oh, we would change her, like, we would bring.
all right, but let's say she
computer
doesn't work at
screen.
a computer. She's just like crap.
Oh,
She is
well, that's what
opposite,
her
isn't
thing is.
All right. But I would also have them squeeze the shoulder blades like
Yeah,
that.
truth too.
That's good. That's
Just
fine.
want to change it.
That's
I know,
fine.
we have
We'll get
this
more
one.
indie. Just be basic.
We,
Right,
yeah,
sit
we
up,
change her computer screen and
neck
then
straight, shoulder
we
blade.
would also say maybe you should get a standing desk to try that.
Okay, very good. Now, final phase. Concentric and eccentric shoulder flexion at multiple degrees of flexion. All right, so good. She's at that scaption. Can we still say scaption?
Yeah, I mean,
D2,
D2 and scaption the same
D2.
thing though?
D2 flexion.
D2 flex. So she's doing flexion at multiple phases, multiple areas, right? Not just straight up flexion. Because now she's getting better. You now could strengthen in multiple phases. Very good. And that's concentric and that's eccentric. What about abduction?
Yeah, I did should lay down.
Okay.
Sorry.
Y, and T.
Okay, we'll buy that. And you would give him a weight perhaps, right?
Yeah.
Yeah.
This side?
All right, now, functional exercise.
Here.
There were 3 exercises specific to this patient's ADLs.
We had like a reaching exercise.
Yeah, we had, the cones, reaching the cones overhead, because that was a huge complaint, is overhead reaching.
So like,
the
if
cones.
this is like, for,
Yeah,
just to
putting
put this
it
in a high.
on a shelf.
Yeah.
Okay, that's a good one. Things along that nature.
We had a thoracic extension over a chair.
Over the, yeah, the back of your
How's
chair.
that functional? It's
is-
not functional, everyday activities.
I was like, she could do it in her chair.
Yeah.
Here you go.
It's not functional, yeah. It's tricky. Another side.
She's performing a pec stretch and the thoracic extension at the same time.
Tell someone not to stretch again.
All right, so
Yeah.
she could do it at her desk.
This she can do at her
Never
desk
tell
without
someone
getting-
not to stretch.
All right, we got it.
And
All
then
right.
the last
Elaine's
one.
favorite.
Yeah. Because doing a belt is a thing, her
Yeah.
problem, circles.
That's good. I like it. It's a good one.
With weight.
What do they call them? Pass-throughs? Well, that's over here.
Or a and like,
That's for
Tangos.
kidney
and like a
stones.
water, you can get a heavy water bottle or whatever.
All right, perfect. Finally, modalities. Your patient
Oh.
requires ultrasound for deep heating to the anterior shoulder. So my 3 questions are, oh, it's E-stim?
It was E-stim.
Am I looking at the wrong one? I am.
You might have been.
All right, E-stim. So, I'm totally looking at the wrong one.
Check it out.
Yes, okay. Discuss how you use E-stim to provide pain control. So what setting of the machine would you use? What?
IFC.
IFC, very good. And you would set the intensity to what?
What is it?
I know
To
the-
control pain.
The frequency is 15.
To
150.
control pain. What would you set the
Oh,
intensity to?
comfortable tingling.
Comfortable tingling.
I'll look
That's
at
what I want you to know.
Yeah,
You
yeah,
got
yeah.
it? So IFC controls
I'll
pain.
think about
Set
it.
it to comfortable tingling.
Yes.
Because we're not, it's acute, we're not gonna invoke anything. Very good. Give this group a clap.